Yeah, I think we can start.
Yes, sir. Good evening, respected professor, my dear students. I welcome you to all to today's session on some important theory topics. Today, first I invite Dr. Kamal Pandian. His topics will be bone cement implantation syndrome and augmented inflow effect. Over to Dr. Kamal Pandian and professor and students.
Hi, sir.
Good evening.
Today, the topic for discussion is going to be on the bone cement implantation syndrome. So, to start with an introduction, bone cement implantation syndrome is a potentially with the use of polymethyl methacrylate (PMMA) bone cement during the orthopedic procedures such as hip arthroplasty, knee replacement, and vertebroplasty. So, this manifests as hypoxia, hypotension, arrhythmias, and cardiovascular. The incidence is around 28% in cemented hemiarthroplasties. Severe grades will be in around 1 to 7%, and the mortality can go up to 1 to 2%. Moving on to the etiology and pathophysiology, the mechanical factors, starting with the mechanical factors, it is the pressurization of the cement, which causes an increase in the intramedullary hypertension, causing to the embolization of fat, marrow, and cement particles and air into the venous circulation. So increased pulmonary vascular resistance will lead to an acute right ventricular dysfunction. Also, the chemical and inflammatory mediators are the PMMA monomer absorption will cause a vasodilation and also myocardial depression. Activation of complement system can cause histamine, serotonin, cytokine release, and which leads to vasoplegia. So the net result is going to be the result will be a sudden pulmonary hypertension and also right ventricular failure, which can lead to decreased cardiac output, hypoxia, and hypotension. Or osteoporotic bone, pathological fractures, metastatic lesions, any revision surgeries, or pre-existing disease, or poorly hydrated patients. These patients are going to be, the clinical features would be the intraoperative signs is going to be a sudden drop in the ETCO2 and also a sudden drop in the saturation, SpO2. There will be hypertension, arrhythmias, and even cardiac arrest. The time will be usually during the cementing procedure, also at the time of processes insertion, joint reduction, or even at the time of tourniquet release. The classification can be graded as grade 1, grade 2, and grade 3, where a moderate hypoxia is where the saturation is less than 94, or hypotension more than 20% of fall in the systolic blood pressure. The grade 2 is going to be severe hypoxia with a saturation of less than 88, or hypertension more than 40% in the systolic blood pressure, or even unexpected loss of consciousness. The grade 3 will be the cardiovascular collapse requiring a CPR. The diagnosis is going to be clinical, intraoperative event recognition, and even an echocardiography where we can see right ventricular dilation, embolic material in the pulmonary artery, and in ABG we can look for hypoxemia, metabolic, or lactic acidosis in these patients. The management is going to be it's going to be the prevention, where optimizing the intravascular volume pre-op, also high FiO2 before cementing, slow and staged cementing insertion, and the use of medullary venting process, also regional anesthesia with close hemodynamic monitoring. The intraoperative, in case if treatment is going to be 100% of oxygen, aggressive fluid resuscitation, vasopressors like noradrenaline, phenylephrine, or epinephrine, and inotropes for right ventricular failure, including dobutamine or milrinone, and CPR if required. The prognosis of these patients is going to be mostly mild cases will resolve with supportive therapy. Severe cases may lead to high perioperative mortality. So in conclusion, embolic and anaphylactoid syndrome, unique to cementing orthopedic surgery, and early recognition, vigilant monitoring, and preventive measures and prompt resuscitation are crucial for successful outcomes. Moving
similar to any other pathological condition? Is this bone cement implantation syndrome, is it similar to any other pathological condition common in orthopedic surgeries? Which can occur on the table or a little later also?
Pulmonary embolism, sir.
Fat embolism syndrome.
Yes,
long
okay, sir.
bones, and they ream the bone for implant fixation.
Okay, sir.
That time they can have fat embolism syndrome, which can happen on the table or a little later also, especially femur fractures. Even without surgery also, patient can develop fat embolism syndrome. Okay? Because
Okay.
the marrow fat, the same mechanism, it can enter the circulation through the open venules from the fractured limb, and then go on the occlude the pulmonary circulation and produce a sudden hypotension. But the features of fat embolism syndrome are little different. What are the three cardinal features of fat embolism syndrome, which also produces a similar picture?
So petechia,
Hmm.
petechia, hypoxia, and
Altered sensorial. Okay,
altered
these are
sensation.
the neurological, cutaneous, and respiratory. These are the three manifestations. So the pathophysiology may look more or less similar. And what are the preventive measures you said? What is the nowadays? Do you find orthopedic surgeons using this cement for implantation? Except
Not much.
they try to avoid it because of these complications. Now there are cementless prostheses are available, especially for the elderly. Hip fracture is notorious for producing this problem. So they have cementless prostheses, which can be just like that inserted without the application of cement and avoid this complication. And is there any role for the anesthetist and surgeon during the time of using the cementing?
So usually we increase the fluid load, and we might provide a vasopressor, or we can even
There
provide a
should be good
hydrocortisone or any
communication
steroids.
between the surgeon and
Communication.
anesthetist. Okay, surgeon should
Yes, sir.
inform the anesthetist that he is going to plant
Cement.
the cement. He is going to use the cement. Caution the anesthetist to be aware, and anesthetist should be present at the time of. Many mishaps have happened because anesthetists, after giving a regional block, they were not present at the site of during the time of cement application, and they pick up the complication later. So that is the reason for the heavy morbidity and mortality that happened. So it is always better that the anesthetist should anticipate this complication and be by the side of the patient and be prepared to tackle and immediately attend to that, from which we can easily save the patient from going in for a major disaster. Okay, that is a very important thing. So this communication and the role played by the surgeon and anesthetist is very, very important. Okay? Right.